Hi, good afternoon, everyone, and welcome to the Centre for Science Communication fourth and final webinar on achieving accuracy in medical journalism. Yesterday was Global Sexual Health Day, so today's webinar on sexual health is timeous. Can you please look in the chat box for links to the previous webinars in the series? The first one provides an overarching view of how to go about researching and writing in medical journalism. We did not make the second one on gender affirming healthcare publicly available, but let me know if you want to know more about that webinar. And the third webinar on vaccine safety and efficacy is also available at the link provided. Today, we welcome 4 illustrious speakers who will tackle issues related to the framing of sexual health in the media, the problem of false information about sexual health, key issues for consideration in sexual health journalism, and how journalism can support comprehensive sex education. And finally, what accurate reporting on sexual health consists of. First up, we have Professor Catriona McLeod, a distinguished professor of psychology and Saatchi Chair of Critical Studies in Sexualities and Reproduction at Rhodes University. She has written extensively in national and international journals in relation to teenage pregnancy, abortion, sexuality education, pregnancy support, reproductive decision-making, sexual violence, sex workers, youth sexuality and contraception. She's also authored, co-authored, and been lead editor on many books, including the multi-award-winning book, Adolescent, Pregnancy and Abortion, the Palgrave Handbook of Ethics in Critical Research, A Genealogy of Puberty Science, and Abortion Services and Reproductive Justice in Rural South Africa. Her work has informed the South African National Adolescent, Sexual and Reproductive Health and Rights Strategy Framework and the National Abortion Guidelines. She has also received many awards, including the Rhodes University VC's Distinguished Senior Research Award and the VC's Community Engagement Award, the Social Change Award, South African Women in Science Award, and the Lifetime Achievement Award for the International Society of Critical Health Psychology. Without further ado, Catriona, please go ahead with your presentation outlining a framing of sexual health in the media.
Thank you, and thank you for that kind introduction. Shall I share the slide presentation myself, or will you do it?
If you don't mind, or I can do it if you want, but I haven't.
Is it showing?
Not yet, but you'll need a few seconds. Let's see. No, it's not showing. Okay. Let me try opening it. Try. Can people see it now? I'm getting weird security alerts. I'm not sure what that's about. Can people see the screen?
Yes,
I think you can go ahead. I think you can go ahead, Catherine.
Okay, excellent. Thank you very much. Okay, sorry for that technical glitch. Thank you for the kind introduction. And, you know, my initial brief was, what are the sexual health challenges faced by South Africans? And my first response, a bit typically like an academic, was what do we mean by challenges, and challenges for whom? And so my take today will be to look at how sexual health, reproductive health is framed. And I want to make the argument basically that in our communications with the public, with students, we need to filter our questions and our understandings through a sexual and reproductive health, justice framing. So I don't seem to be able to move there we go. Okay, thank you. All right, so this is the question: is how are issues framed around sex and sexual health? And I'm going to present 5 main focuses. The first one is the medical focus, and basically with this sort of focus, the focus is on the body. So looking at disease, dysfunction, disorder. And the major kind of action there is diagnosis and treatment. So in terms of sexual health, it's STIs, HIV, sexual dysfunction, disorders during pregnancy, etc. And as well as, of course, at looking at prevention and promotion activities. So, for example, contraceptive care, antenatal health care. The second framing is public health framing. And this is related to the medical framing, but it focuses instead on the population. And the key activity there is to look at epidemiology, and in other words, population trends. So, for example, in sex and sexual health, distribution of STIs, unintended pregnancies, contraceptive use. And within that, to look at what are the determinants of ill health, and to then see how health systems interventions can intervene to reduce ill health through attending to the determinants thereof. The following one would be your public health, your population control framing. And that is a framing that emerged post-World War II, when former colonies were gaining their independence. And the narrative there was that for economic development to proceed, you had to curb population growth. And this was a guiding policy principle globally up until about 1994, but it had a lot of very negative implications, including coerced sterilization of those who were seen as unfit to reproduce. This moved on with, in 1994, with the International Conference of Population and Development, in which the Cairo Program of Action was launched. And it then, so population control then moved to sexual and reproductive health and rights, with a shift from looking at numbers to looking at human rights. And with sexual and reproductive health being seen rather as a state of physical, mental, and social well-being, rather than simply an absence of disease, which we would see in the medical framing. And in order to do that, you would then have to have rights that are attended to. Finally, there's the sexual and reproductive justice framing. Now, the sexual and reproductive justice framing does not issue a medical framing or a public health framing or a rights framing. It does more or less the population control one, but the other framings it does not issue, but essentially says that when we are speaking in those terms, we need to understand inequities. We need to forefront health inequities and analyze the power relations that underpin these health inequities. And importantly, it's in analyzing those power relations and these inequities, we need to understand the intersectional nature of this discrimination. In other words, to see how gender, race, socioeconomic status, location, religion, language, disability, etc. intersect to create health inequities. And 2 major kinds of procedures are used here. One is to look at and analyze normative assumptions, sociocultural normative assumptions, and the second is to look at structural issues and how structural possibilities and challenges may either enhance or inhibit health inequities. So what I'm going to do now is to ground this in a particular sexual and reproductive health issue, HIV, which we know very well, just to make it more make more sense in terms of a particular issue. So The medical framing here would be research, administration, monitoring of antiretrovirals, mother-to-child transmission, vaccines, pre- and post-exposure prophylaxis. Your public health framing would look at prevalence, look at incidence, and we can see there that in South Africa there's been some success in terms of incidence with it reducing, and things like the UN 95 target, which is that people living with HIV should know their HIV status. Those living with HIV who know their status should be accessing, 95% should be accessing treatment, and above those accessing treatment, 95% should be virally suppressed. So you can see in South Africa we're a bit behind on that in 2024. A population control kind of take on this would be, well, you know, should women with living with HIV be mothers? And we have seen cases recently of women living with HIV being coerced or forced to into sterilization. Moving on to sexual and reproductive health and rights. It would be looking at undermining barriers to accessing treatment and preventive services. So, for example, looking at marginalized individuals who do face barriers, such as transgender individuals, adolescent sex workers, people living in rural areas. Your sexual and reproductive justice framework would then start to ask questions. What are the norms? What are the structures that underpin axes of discrimination around, for example, prevalence barriers to access discriminatory treatment? So, for example, why is it that women are twofold more likely to be living with HIV than men? Why is it that transgender people struggle to access HIV services? And what is it about women of reproductive age living with HIV that they're seen as inadequate mothers and therefore coerced into sterilization? For the rest of the presentation, I'm going to focus on a key element of the sexual and reproductive justice framework, and that is questioning normative assumptions. And what I want to do here is to focus on adolescent sexual and reproductive health and rights, which is a big kind of topic in South Africa. And I want to start with the question, with an assumption around pregnancies. Is it teenage pregnancies that are the problem, or is it unwanted or unsupportable pregnancies that are a problem? We know that every few months the media outlets basically shout concern about teenage pregnancy. I've been in this game for about 30 years, and the same tune appears every now and then. There's moral panic about teenagers becoming pregnant. Numbers are touted and actions are demanded. But if we look at the graph that's there, it says figure 5, it's a very interesting graph, and it starts to pose this question about whether it's unwanted or teenage that's the problem. That graph shows the percentage distribution of unwanted births in the last 5 years preceding the 1998 South African Demographic and Health Survey and the 2016 Demographic and Health Survey. So 2 surveys conducted almost 20 years apart from each other, showing almost identical trends. And that is that women who say that they've had an unwanted birth in the last 5 years increases with age. So if we look at the category 35 to 44, there are a lot more women who say that they had unwanted birth than those under the age of 20. We know from the literature that unwanted births are associated with a host of negative social, health, and economic outcomes for both the mother and the resultant child. So I just leave you to ponder this particular bit of information. But I want to draw your attention to, in the last little bit, if we can just go back one slide, sorry, is the notion of single axis thinking. And this is what the focus on teenage pregnancy does. It foregrounds age, as if all teenagers are the same. Without taking into consideration the complexities of teenagers' lives. These are completely glossed over. And the sexual and reproductive justice framework reminds us to think intersectionality, to overlay wealth, access to antenatal care and education onto our understandings of pregnancies. And when we look at well-designed comparative research that matches younger and older women, pregnant women on socioeconomic status, access to antenatal care and education, what is remarkable that emerges is, in fact, that socioeconomic status is a major factor in the negative outcomes in terms of pregnancy and health and social and economic issues for mothers and resultant children. So the final thing that I want to talk about then is that one of the things that that is touted a lot in terms of adolescent sexual and reproductive health is youth empowerment. Surely that's where we should be going, is empowering the youth around sexual and reproductive health issues. I want you to just take a look, if you can put that billboard up, just click twice and you should get to the billboard. Once more. There we go. There's a billboard there that is very clearly about youth empowerment, inciting people to think about books before their babies and always have safe sex and to matriculate and then to work with graduation, to graduate. I'm going to hand over in this YouTube clip here to a PhD student. If you can play that, if it's going to play.
Sure how to be able to play. Hold on. Oops. Sorry, my screen is gone funny. This one is just the thing.
Sorry, when I was doing the practice, it did play.
Oh, this why is it not playing? There we go. The context. There we go. Sorry about that.
Okay. This is Cassandra Robertson, who's doing her PhD, and she explains the complexities around empowerment a lot better than I can.
Is it playing? No, it's not playing. I don't know why it's not playing. Oh, I'm so sorry.
If you click there down, there we go.
It's asking me to change my account privacy. That's why it's not wanting to play. Which I don't really know what that means. You want to share the link in the?
I will share the link in the chat, and then people can have a look at it. But essentially, what she is arguing there, it's a 3-minute clip, and it's really worthwhile watching. But essentially, what she's arguing is that in the youth empowerment programs, you have two conflicting discourses. The one is that young people are vulnerable, and the other one is that they're resilient. And these two essentially conflict and create mixed messages, basically saying that young people are responsible for overcoming the social disadvantage, economic disadvantages within their context. I'll put that in the chat. She does it far better than I do in that, but it's really worthwhile watching. Thank you. And that's just a link to our critical studies in sexualities and reproduction.
Great. Thank you so much. Let me stop sharing. There we go. I think that emphasis on sort of power is very much key to what we want to get across today in terms of if we want people to have sexual and reproductive health, they need to be empowered. So thank you for that very insightful contribution, Catriona. Our next speaker will be discussing beyond the framing of sexual health, where are we at as a country in terms of sexual health? What are the issues? Where are people accessing health and so on? So our next speaker is Imidibaniso, and she's the South African Research Chair in Gender and Childhood Sexuality at the University of KwaZulu-Natal. Her research spans the intersecting domains of gender, sexualities, childhood studies, and education. She has published 12 books, including Girls and Porn in South Africa, Power, Play, and Sexuality, and her latest book, Gender and Young People's Digital Sexual Cultures. In 2022, she was awarded the HSLC USAF award in social sciences and is a B1 NRF rated researcher. Divya, please go ahead with your insights on the state of sexual and reproductive health education in South Africa.
Thanks very much. Can you see my PowerPoint? Rebecca?
Yes, we can see it. Can you share the slideshow?
Okay. Okay, can you see it? Because I have it online. Can you see it?
It normally takes a few seconds to update, so let's just see what happens. No, it's not sharing.
Let me do it again.
Okay.
Now?
It's sharing the PowerPoint, but it's not sharing the slide presentation. So I don't know if you just want to go ahead and we'll just
All
see
right,
it the
I'll
way
go
that
ahead.
it is. Yeah.
Okay. So, so my task was really to provide insight into the state of sexual and reproductive health education in the country. And my, or the punchline for my discussion is really that sexual and reproductive health education in the country is essential, but a contested field. It is marked by unequal access, persistent gendered and cultural norms, and the proliferation, unfortunately, of medical misinformation. So despite progressive policies and global recognition of the importance of such education, we are confronted with deep inequalities, heteronormative assumptions, and moral panics that undermine accurate, evidence-based communication. Journalists do play a critical role in shaping public understandings of sexual and reproductive health, but their reporting is often vulnerable to sensationalism, stigma, and the circulation of misinformation. And so quite briefly, South Africa's sexual and reproductive health education is not failing for lack of policy, but it is undermined by a moralized information environment where gendered power inequalities and, of course, in current times, digital misinformation converge. Journalism that treats sexual and reproductive health as a rights and justice-based approach rather than one based on morality or individual behavior can correct falsehoods, shift harmful framings, and move responsibility from individuals, mainly individual girls, to systems and actors that constrain their choices. So in terms of setting the scene, the previous speaker has elucidated the context in the country, including HIV, unintended pregnancy, and of course, sexual violence. So despite reporting or low reporting about HIV, the incidence among 15 to 24-year-olds was 0.39% nationally. However, and despite the fact that there are reduced rates of infection, it is consistently higher in females than males. Between 2023 and 2024, it is reported that 122,000 teenagers between the ages of 15 and 19 were pregnant, and more than 2,700 girls aged 10 to 14 gave birth in the 2023-2024 financial year. So what this does is clearly to set the very in terms of the numbers, very clearly what we are confronted with. But at the same time, the ways in which the reporting happens seems to suggest that this is a problem of immoral girls. In fact, in terms of sexual violence, we in sub-Saharan Africa, about 79 million girls and women, or 1 in 5, have experienced rape or sexual assault before turning 18. And in South Africa, the reports that sexual offences in the country nearly tripled in 4 years, from 25,000 in 2020 to 21 to 73,000 in 2024 to 2025, and approximately 40% relate to children and girls in particular under the age of 18. So what these statistics suggest to us is clearly a country that is confronting huge issues related to sexual and reproductive health. And I think when I began preparing for this, I first thought about what does sexual and reproductive health mean? Now, we followed the World Health Organization definition of sexual and reproductive health, meaning that we are focusing on physical, mental, social well-being, concerning all aspects of the reproductive system. Well-being is based on the right of people to engage in sexually satisfying and safe sexual lives, alongside the right to determine if, when, and how often to reproduce. Now, sexual and reproductive health and well-being require an education and healthcare that addresses pleasures while also protecting young people's sexual risk and preventing HIV, unwanted pregnancy, and sexual violence. In South Africa, as I've noted, we don't have a problem with policy. Of course, policies implementation and nuanced versions of policies are required, but the policy context is very clear in terms of health and rights protected by the Constitution. And just to remind our viewers, right to health care, body autonomy, control over reproduction, contraception, family planning, safe pregnancy, they are all very clearly listed in what sexual and reproductive health and policy and rights mean in this country. In terms of my focus on young people who are mainly located in schools, comprehensive sexuality education is embedded in life skills and life orientation since 2000. There are also several other policies, including the HIV, STIs, and TB policy, with the integrated school health policy, which underpin health promotion. And I could name many more, but rather than that, the point that I wish to illustrate here is that sexual and reproductive health education, it is not failing for lack of policy, but is undermined by a moralized information environment where gendered power inequalities and misinformation converge. So what then is the challenge? The challenge is to address conservatism, homophobia, xenophobia, transphobia, and the gender wars which are underpinned by patriarchal norms and undermine sexual health and reproductive health. As noted earlier, we cannot understand sexual and reproductive health without understanding the way it is embedded within social structural inequalities, which overburden healthcare systems and provide unequal access to health in this country. Another important issue that is emerging, particularly in terms of the global flows and digital misinformation, are the ways in which religious norms and political polarizations work to contest young people's right to sexual and reproductive health. There is also complacency around HIV. The health fractures then exist along lines that are based on region, in terms of rural-urban disparities, race, class, ability, as well as sexuality, including age disparities. Of significance in terms of journalists and reporting are the common myths that prevail. In my own research, it's been obvious that saying sex is disrespectful. In fact, in interviews conducted with adults, even saying the word sex to me in an interview raised discomfort. And it speaks to how difficult it is to talk to young people about sex, about the penis, about the vagina. In fact, it is considered to be disrespectful. Another common myth that prevails is that talking about sex makes young people have sex, and that comprehensive sexuality education, because we talk about sex, sexualizes children. Another common myth prevailing is that young women who access contraceptives lack morals. Abstinence education is deemed to be the only way for prevention. Now, there are many other myths, and some of them include that condoms have holes and that let HIV through, and that abortion in this country is illegal for minors without parental consent, which we know, according to the law, is not true. Another common myth is that you cannot get pregnant at the first time or during the first time sex or during a period. Now, here I want to pause and return to this anti-comprehensive sexuality education crusade and the role of media. In the last couple of years, we have seen the growth of a right-wing crusade with global flows of information against the rights-based comprehensive sexuality education, promoting anti-abortion and abstinence. And as such, it prevents discussion on sexual pleasure, on sexuality more broadly, and on gender diversity. The promotion of traditional values rooted in religious and moral principles serve to reinstate gender norms rather than to contest it. So why are these anti-comprehensive sexuality education crusaders seen as the most important voice? And why and what role can journalists and the media play to challenge this? And I would ask, where are the voices of young people in reporting about sexuality? What is the research telling us with young people? And why must the media work with researchers in the field to provide alternate points of views? What about the rights-based context that could challenge the crusade against gender and social justice? So beyond the sensationalism, the role of journalists is really to report beyond, of course, medical facts and beyond that. We need to contextualize evidence within the histories of inequalities, gender norms, cultural contestations, and the actual lived realities of young people. And if there's any message that I would like to send from this presentation, is that we must prioritize the voices of the people that matter, and that is the young people themselves. The accurate reporting can correct the harmful myths, it can humanize people, and can highlight the intersections between gender, race, class in shaping sexual health outcomes. And it can also expose the policy implementation gaps and the political contestations which undermine the right of young people to sexual and reproductive health, education, as well as pleasures and well-being. In conclusion, sexual and reproductive health education remains an ongoing site of struggle between evidence, rights, and misinformation. To ensure that young people's health and well-being and their rights are met, journalists must resist sensationalism, and we must amplify at the same time science and a gender-just perspective. We should promote the law. For instance, the age of consent to sex is 16, but children between 12 and 16 can consent to medical treatment, to abortion, and to contraception. And finally, when journalists resist sensationalism, center science, and expose structures that constrain choice, coverage stops offloading responsibility onto young people and girls in particular, and starts advancing young people's health, rights, and futures, and their rights as prescribed in this country. Thanks very much.
Thank you so much, Divya. We definitely need to focus on contextualizing sexual health more in terms of, instead of using moralizing frames, what are the dynamics that are creating sexual health issues in South Africa, and what are creating the sexual health challenges in terms of access and rights. You have touched on the topic of misinformation, but we're going to get more into that now. Dr. Kim Jonas is going to give us a lot more insight into the kinds of false information circulating in the public domain, especially among adolescents. Dr. Jonas is a senior specialist scientist in the Health Systems Research Unit at the South African Medical Research Council. She leads a portfolio of research which seeks to understand the factors influencing the sexual and reproductive health of adolescents and young people, including other vulnerable populations in low-resource settings in South Africa. Her research speciality is on access and use of sexual and reproductive health services, unintended pregnancy prevention, HIV prevention, and universal health coverage, specifically universal access to sexual and reproductive health services. She has over 10 years working experience, leading as a project primary investigator, several large cross-sectional household school surveys, including implementation science studies. She is a Y-rated NRF scientist, a review panel member for the World Health Organization Sexual and Reproductive Health Program, and editor at BMC's Reproductive Health Journal. He has co-authored over 50 peer-reviewed journal articles, 2 book chapters, 4 policy briefs, and 6 research reports. Kim, please go ahead with your insights on how false information is impacting on sexual health and access to sexual health services in South Africa.
Thanks, Rebecca. It seems I'm unable to share for some reason. Will you allow me to share my screen?
You should be able to share.
I keep clicking and nothing is happening.
Oh dear.
I can quickly try go out and come back quickly and see if that's going to work.
Yes, I think do that.
Okay.
Because you should be able to. Okay, Kim, do you want to try again?
I'll try. Okay, there it's allowing me to do so now. Thanks.
Great, thank you. Sorry about that.
Yeah.
We can see your slide.
Before I do this, sorry. Okay, great. And put away.
There we go. You can see.
Thanks again, Rebecca, and good afternoon, everyone. Many thanks for the invitation to speak to this very important webinar. It really could not have been a perfect timing, as you mentioned in the start of the webinar. We just commemorated World Sexual Health Day yesterday. I'm going to follow up on what other presenters have talked about. Particularly, my focus is on the myths and miscommunication around sexual and reproductive health. I'm going to start more broadly with the myths, and some of them you've had in our just recent speaker now, and then move on to from the general sex to HIV and AIDS related myths and miscommunication, and then move on to the contraception and pregnancy related myths and miscommunication. I'll also include some of our research findings or quotes from our participants, because I do a lot of research in sexual and reproductive health among adolescent girls and young women in the country. So I'll be sharing some of these insights from them. You know, up first, I think we've had this many times that when it comes to condoms, they are too small for the African man penis. And we know that our brothers may be resistant in using condoms because they think they're too small. You see in the illustrated image, they literally measure the pack of the condom, not the actual condom inside, by the measurement. And next, so in the sexual and reproductive health, it's really important that correct understanding of SRH services and commodities is communicated widely and publicly, as it influences the use or non-use of the services. This also relates to the societal norms that you've also have just heard about, which are often held high, particularly by the young people, as it is demonstrated in this quote where one of our research participants seemed to believe that condom use is dependent on the male partner. Obviously, this narrative needs to change, and that is where journalists also come in, ensuring that they communicate a gender balance and positive views about SRH and other commodities for young people in particular. Here, the quote highlights the misconception or misinformation about pregnancy or conception and the acquisition of an STI. Sure, the withdrawal method may work to prevent pregnancy, but it does not prevent STIs at all. And this kind of understanding and common beliefs really affect the uptake of contraceptives and use of condoms. I mean, we know that dual protection is very important, but with the understanding or with the beliefs from young women about condoms and contraception, this is unlikely to yield any benefits in the long run. We're still struggling with the HIV rates and unintended pregnancy in the country, as you've heard earlier. Now, there's plenty of these, and every time we interview our research participants, we come out with new or more myths, depending on where you are around the country. And so it is very important for journalists to know their audience and ensure to debunk these very dangerous myths and misconceptions, specifically those that are localized in specific regions. I mean, every region in the country, as we've got 9 provinces and different traditional and religious practices, there are different myths and misconceptions, and one who has a public platform and a public role needs to understand which ones are more prevalent in what area, and try to communicate correct and accurate information about these, as they really affect uptake of SRH services. This is just another one that has serious and detrimental consequences into one's reproductive health, where it is believed that going to pee after sex prevents STIs. These are the beliefs of young people, and we know that any effects or any unintended consequences appearing at the early age of a young person has a long-term effect throughout their reproductive health, and that without averting and really demystifying these myths, we're sitting with the problem for another 30 years plus or another 100 years. Now we're moving on to contraception, another very old myth which you've seen earlier, and both earlier speakers have spoken about it, where they believe that contraceptives cause infertility. Today's generations also still believe this, and we have a moral responsibility as researchers, public health practitioners, journalists, and all other key role players, from influencers and role models in the country, to communicate accurate information, because this is not going to change the status quo of the rising unintended pregnancies among our young people. With the challenge of rising teenage pregnancies I've just mentioned, this particular myth is deeply concerning. Yes, sex is a pleasurable act, and it is understandable when people want to enjoy it, but contraceptives do not affect sex pleasure, and our young men and girls need to be well informed about this. And this could be done through comprehensive sexuality education, including comprehensive contraception counseling when they come for the services. And this is also another key role for the journalist or the medical journalism, that through their public platform and spaces, they have the moral responsibility to communicate accurate and correct medical information, to eliminate or try and eradicate as much of these negative myths and miscommunication among young people, and also broadly among the broader population or the broader society, because these are misinformation held within a community and a society, and addressing this from a societal point of view is really critical. We've seen many of the contraceptive-related myths and miscommunication, and here one of our participants, or from our research participants, say that why they are not using contraceptives because it damages their body. I mean, many girls indeed believe that contraception damages their body, and therefore they're not using them or not keen on using it. another long-held quote illustratively showing the very strong held myths about the dangers of contraception. Now, we would not obviously do any much justice into eradicating unwanted pregnancy or unintended pregnancy if we don't correct this misinformation. Surprisingly, even the boys believe that if their female partners are using contraceptives, it will make them infertile. And as you can see in this quote, this girl is speaking to her boyfriend, and her boyfriend is articulating that his friends say that the contraceptive injection used by his girlfriend will make him infertile. This is another very concerning one, and probably relatively new in the drug mixing concoction days of Nyawupe, where young girls saying that they mix aspirin with Coke after having unprotected sex. Now, I'm not sure any of us know what the implications of this, but just with the increasing rise of substance use, it is giving a serious problem that we might have another pandemic on top of another pandemic if we are going to let these myths uncorrected and continue growing from one generation to another. A newly discovered one from my end is that if you drink Stamita after having unprotected sex, you can induce abortion. This medicine is obviously not accurate, not a proper or true reflection of what can you do with abortion. With the increasing and worrisome consequences of illegal abortion or unsafe abortion, things like this need not to be known by the young people or even by the public at large. The media or the journalists are really key in ensuring that these kind of messages are debunked right away. I've been talking about contraceptives a lot, and this one is also another one that just shows how much inaccurate information is out there about sexual and reproductive health, highlighting the need for the escalated efforts in communicating correct medical information, which can save lives and promote quality of life, and more importantly, improve the uptake of SRH services from a young age or from an early age, particularly among young girls. Finally, I will focus on the HIV-related myths and miscommunication. In these next few examples, here our participants believe that PrEP affects the sexual drive, and thus those who are in a relationship do not find it wise to take PrEP. Again, with the rise of HIV incidents in the country, this is quite concerning, and it needs to be addressed. Recently, with the pregnant women, they believe that taking PrEP will prevent their babies from STIs, not necessarily that it will prevent themselves from contracting HIV, but also from passing the HIV on to their unborn child. It seems they're doing it for their babies, specifically for STIs. And here, another popularly held view, where it is believed that when one partner is taking ARVs, condoms are not necessary to be used during sex. I'd mentioned earlier the importance of dual contraception, where you use condom plus a contraceptive method. Clearly, the understanding that ARVs do not treat or cure all other STIs, but HIV is broadly out there, and it needs to be corrected. And finally, the view that once one starts taking ARVs, the U equals U kicks in immediately. So you can see how crucial medical journalism is in communicating accurate medical information to the public. Given their standing in public platforms, it is very important to ensure that these myths and misconceptions are corrected on a wider scale, as they have significant impact in the overall sexual and reproductive health and may have long-lasting consequences. And this is the end of my presentation. Thanks very much.
Thank you, Kim, for highlighting some very concerning myths that are circulating about sexual health in South Africa. Clearly, the media have a role to play in correcting this false information and providing the public with accurate information. So next up, we have Constance Mate, who's going to make some suggestions about how the media can better report on sexual health matters. Constance Mate is the National Coordinator of the Azijiki Coalition for Decriminalisation of Sex Work in South Africa and the Board Chairperson of the Sexual Reproductive Justice Coalition She's also a Strategic Advocacy Human Rights Fellow, a Global Atlantic Fellow, and a co-founder of the Black Sex Work Collective. Constance produces and presents Straight Talk on sex work on Cape Town TV, spotlighting sex worker rights and policy reform. With over a decade of experience, she has worked with organizations like Triangle Project, the Desmond Tutu HIV Foundation, and the Women's Legal Center. She holds diplomas in project management and legal studies, and currently serves on the Women's Rights Watch Advisory Board. Through her leadership and media advocacy, Constance continues to champion the decriminalization of sex work, amplify marginalized voices, and push for gender justice and legal reform rooted in dignity and equality. Constance, please go ahead with your thoughts on how journalists can provide better, more accurate coverage on sexual health issues. Constance? Constance, are you there? I'm sorry, I'm not sure why Constance is not. We can't hear Constance. It's not. Constance, I don't know if your mic is muted.
Hello, yeah.
There we go. There you are. Thank you.
Yes, can you hear me?
Please go ahead.
I'm just struggling with my network.
Okay. Yes, we can hear you.
Right. Rebecca, did you receive my presentation? Hello, Rebecca.
I'm just checking whether I received your presentation. Just hold on a second.
Okay, thank you.
No, I haven't received it.
Okay, I don't know whether can I share my...
Oh, I've got it now. But you can share your screen.
I can share my screen?
Yes. We can, if you, I can also share. I've got it open now if you would like me to share. Shall I share, Constance? There we go.
Yeah, you can share. Okay.
Oh, we can see your screen. There we go.
Oh, you can see my screen now.
Yes.
Okay, but you aren't going to be able to see my face.
Well, no, we can see your face and your screen at the same time. Or I can. It just depends on what.
Thank you. I was so worried about that.
No, it just depends on what options people have selected.
Thank you so much, Rebecca. Thank you so much for everyone for inviting us, and we truly appreciate and the support of the work that have been done. I'm going to speak. I can see everyone have touched every way. I'm going to be speaking in a perspective of an activist, right? Before I go forward, I have introduced my name. My name is Constance Notandomate. I am ACG, the National Coordinator for the Coalition of the Decriminalization of Sex Work. Why the accuracy matters for me? The first thing is the journalism. Shapes the public opinion on health decision and misinformation that can lead as the advocate for criminalization of sex. I have seen it in many platforms, in many spaces, in many interviews or newspapers or TV, even, where people, they do the misinformation that harms the sex workers. And accurate reporting, it totally builds a support to a trust and support to the public health. It kindly also give the fact to our community to respond on on our issues. And then the impact of maybe about the HIV, STI, contraception, and sexual rights persist. Inaccurate reporting fuels the stigma and discrimination, lead to poor health and seeking behavior and police setback. As we all know, we have been advocating for decriminalization of sex work. So the criminalization, once the poor are reporting, as they say, it fuels the stigma and discrimination. It delays the policies and the laws to change. This is the one of the aspects why we are still struggling and sit on criminalization until now, until today, using the 1957 laws. The language matters. Words influence the perception and dignity. Problematic, for example, some newspaper, they use the words like mahocha, prostitute. All those words, that's not what sex workers want. Sex workers want to be called sex workers. But those kind of words, when I remember the other time, when I called the Voice newspaper and when they used the word mahocha, I asked them why did they use that particular word. They tell me that it's because of the sales of the newspaper. So they use it for their own personal gain without looking that these kind of things, they harm the sex workers on the ground. Calling people AIDS victims. Respectful, we prefer sex worker or person living with HIV. Person-centered language, respect plus better is outcomes. Human rights and sexual health. Sexual health cannot be separated from human rights. Accurate journalism can support the police change, for example, such as decriminalization of sex work. Informed reporting strengthen the advocacy. So once you have the whole information, reach out to us. If you don't know anything, ask us, and then that way you are strengthening the advocacy. It makes the way easy. The process of changing the laws and policies, it make it easy. Evidence-based resources use scientific data into accessible language before you publish. Journalists, communities, journalists should include the experience. Such as the sweat, such as the asijiki, will reach out to sex workers for you. Capture the real story. Don't go and edit other people's stories. So when someone is sharing their own story, their own lived experience, it's better coming from the owner of the person rather than people. They misunderstood the story and then they capture the wrong information. Not justice statistics. Report with the communities, not just on them. Let them be the part of the process of reporting. Lift the voice of the sex workers, people living with HIV and other marginalized groups. Evidence-based reporting. Use included. Oh, I have already done that slide. Ethic reporting. Protect autonomy and safety and sensitive stories. Avoid sensationalism. on dignity, balance public interest with human rights. Don't do it for your personal views, but rather balance with the human rights, because the sex work is more about human rights. It's not about your perception, how you feel, how you see it. And our partnership. We are a partnership with the different organizations, coalitions, and advocates. And for you as a journalist, it's mostly important that you can reach out and support the data that you are given and the context by those movements. Collaborate approach, strong, more truthful reporting. Together we shape the narrative that serves lives, not that destroy the lives. My closing message is the accurate, respect, and the evidence-based journalism serve lives. By reporting responsibly, we break the stigma, influence the policy, and protect the health and the rights of all communities. And then thank you. If you want to follow us, these are my social handles and this our website.
Thank you so much, Constance.
That's the end of my.
I think that we can all agree that journalists have their work cut out for them if they want to improve accuracy in sexual health reporting. We need to focus on, if we want people to access sexual health, we need to focus on their sexual health rights. Thanks, Constance.
Hello.
Constance, can you stop sharing your screen now? Thank you. So, are there any questions before we close off?
Yes, I'm trying. My network is bad.
Does anyone in the audience have any questions that they would like to raise? Okay. In that case, thank you to our speakers and everyone who attended today. Also, thank you to the supportive team at the Center for Science Communication in the Journalism Department at Stellenbosch University, to my supervisor, Prof. Mahita Ikani, who supported my work in putting this series together, to my fellow postdoc, Christelle Antonides, for being my backup and moral support, and to our wonderful communications officer, Fumani Dwara, for successfully promoting the whole series and editing the event recordings. We will be sharing a recording of this webinar on YouTube in coming weeks, and the link will be emailed to you at the email address you used to sign up to the webinar. Again, please look at the links in the chat box regarding the previous webinars in the series. If you've got any questions about this webinar or the previous webinars in the series, please don't hesitate to contact me. My email address is in the chat box. That's rpointer@san.ac.za. And if you'd like to be on the mailing list for the Center for Science Communication, please contact Fumani Dwara at fumanim@san.ac.za. With that, I'll close off and say thank you and goodbye.
Thanks, everyone. Bye.
Bye-bye.
Thank you.